morning, everyone, and afternoon, depending on where you're joining us today. My name is Maria Gutierrez, and I welcome you to the Chagas Echo session for today. We're excited to have everyone join us today. This session is brought to you by the Rockefeller University, Clinical Directors Network, Texas State University, San Diego State University, and UT Health San Antonio Echo. Like I mentioned, my name is Maria Gutierrez, and I represent the UT Health San Antonio Echo Super Hub. I do have some announcements before I pass things over to Dr. Nagalingam to continue with the introductions. We'll start off with some introductions and announcements, then we'll move on over to some speaker presentations and Q&A. Today's topic of discussion is Chagas disease among people living with HIV and other immunocompromised groups. This is the fourth session of a four-part series. We will be offering 1.5 continuing education credits for providers and nurses for each session. Please make sure to fill out the evaluation survey to claim any credits that you might be seeking. The link will be shared at the very end of the session, and you will be able to see the QR code in just one moment. We do ask that everyone please stay muted unless you are speaking. During the session, we do encourage everyone to share their insight and perspectives. So at that time, please, we do ask that you unmute, raise your hand, or use the chat function. Finally, please note that no protected health information is allowed in either the chat or discussion for today's session. For everyone new to ECHO, ECHO stands for Extension for Community Healthcare Outcomes and is a model of lifelong learning and guided practice that connects community-based healthcare workers and a multidisciplinary team of subject matter experts to create a community of practice and learning. The heart of the ECHO is the case-based learning concept, and we are all learners and teachers in this space. To introduce you to our moderator, Dr. Sudha Nagalingam is an infectious disease and HIV physician at El Rio in Southern Arizona, where she serves as medical director of the Special Immunology Clinic, one of the region's largest Ryan White-funded HIV clinics. Dr. Nagalingam, the floor is yours.
Thank you so much, Maria. I'd just like to welcome everyone to this great learning session. Quick note about Clinical Directors Network. It's a New York City-based, practice-based research network and is an AHRQ designated center of excellence for practice-based research and learning and a network of safety and PBRNs. Dedicated to improving access to care and clinical outcomes for low-income and medically underserved communities by creating community academic partnerships around research, education, training, and service. Next. So just a little bit about our session today. It's Chagas Disease Educational Series 2 for community-based clinicians and staff. It's a accredited educational series with extension for community health outcome sessions. Well, our plan is to work with local and state public health agencies. We've gone through 3 sessions already. So the first was local and state public health agencies. Second was recommendations on how to screen, diagnose, and treat Chagas disease at FQHCs. And third was global to local surveillance and transmission of Chagas disease in the United States. Our fourth session, which is today, is about Chagas disease among people living with HIV and other immunocompromised groups. Next. I'd like to introduce our renowned speakers, both Dr. Eva Clark and Dr. Peter Chin-Young. Next. Next. So Dr. Eva Clark has personally helped me at our program here at El Rio. She's been a great resource, and she's an assistant professor of medicine and pediatrics at Baylor College of Medicine, specializing in infectious diseases and tropical medicine. She's co-leader of the U.S. Chagas Disease Providers Network, director of clinical education at Baylor College of Medicine, National School of Tropical Medicine, and the medical director of the Harris Health Tropical Medicine Clinic. Her research explores how tropical infectious diseases contribute to chronic illness in underserved populations. And Dr. Peter Chin-Young, he is the Associate Dean for Regional Campuses and a Professor of Medicine at UCSF. He's a specialist in infectious disease and immunocompromised patients, and he founded UCSF's Immunocompromised Host Infectious Diseases Program. He's nationally recognized a medical educator, having received multiple teaching awards, including the UCSF Henry Kaiser Award for Excellence in Teaching. Dr. Chin-Young has been a prominent voice in public education on COVID-19 and monkeypox, advocating for equity in health and structural reform. He was awarded the 2022 Carl Sagan Prize for Science Popularization. Next. So a little bit the CME, CNE evaluation. So to continue to obtain CME credit, you must complete the evaluation form. And here is the link to the QR code to be taken at the end of the session. Thank you. So I believe we have Dr. Clark to take it away. Thank you.
Hey everybody, sorry, I was having some trouble unmuting. Can everybody hear me now?
Yes, we can hear you, Dr. Clark.
Okay. Well, it's a pleasure to talk to everybody today. The first part of this presentation, my part, is going to focus on Chagas disease in people with HIV. And thank you for the kind introduction, Suda. I appreciate that. So, there's three main objectives that I have for everybody today. The first one is just to review the various presentations of Chagas disease in people with HIV. And in case you're not familiar with the acronym PWH, you're going to see that a lot on my slides, and that just stands for people with HIV. I'm also going to talk a lot about the management of T. cruzi reactivation disease. While uncommon, this is a very important and can be a very dangerous manifestation of Chagas disease. And then I'm also going to try to emphasize very heavily how important it is to screen patients for Chagas disease before they become immunocompromised. So that's my third objective today. I do have some disclosures to mention. I receive royalties from a couple of textbook companies. One of those is related to the Chagas disease topics for Up to Date. I do receive some research funding for Novartis and an honorarium from the American Academy of HIV Medicine, but none of those directly impact what I'm talking about today. So, as most clinicians will want to do, I really want to start with a case. And so this is a 49-year-old lady. She is coming to your hospital with 3 weeks of confusion. Also, she had been complaining of very severe headaches. And her family had noticed increasingly significant right-sided weakness. So, because she's not able to verbalize a lot when you first meet her due to her confusion, you don't know a lot about her medical history. But you do know that she is from Honduras and she's been living in Houston for at least a little while now. When you examine her, she doesn't have a fever. She is confused, and then you, on your exam, reproduce her upper and lower extremity weakness, but you cannot identify any sensory deficits. On the labs you get, real quick at admission, you see that her screening test for HIV is positive. Her CD4 count is very low. It resulted as 38, and then her viral load was 375,000. You do head imaging, and that includes a MRI of the brain. That showed that she did have two ring-enhancing lesions, and they were surrounded by areas of edema that were causing regional mass effect. So, my question for the audience, and I do have this as poll everywhere, is at this point, what is in your differential diagnosis? Hopefully, most of you guys have used Poll Everywhere before. You can access this poll by going to the address you see up here, POLLEV.com/ my name, Eva Clark 437, or just put your phone's camera on this QR code. And I'll give you guys a couple of seconds to respond. Or I will say, if the poll's not working, feel free to put comments in the chat. Oh, there we go. All right, good. I got toxoplasma, of course, T. cruzi, based on the topic of the talk. Any other answers? All right, well, for time's sake, I will keep going. With this patient, she ended up undergoing a brain biopsy, and the biopsy showed the image that you see here on the right. So this was interpreted as the tachyzoites, the active form of toxoplasmosis. And so she was treated with first-line therapy for CNS toxoplasmosis, which is sulfadiazine and pyrimethamine. She did not have significant improvement, but still was discharged on hospital day 14. So she was inpatient for 2 weeks. Um, as I mentioned, she didn't improve while she was inpatient. And so she was actually readmitted to our hospital after being outpatient for a few days. She had another MRI done when she was admitted, and it showed that the lesions that had been seen earlier at the previous hospital were getting worse. This time, serologic testing was sent for both Toxoplasma and Trypanosoma cruzi. Toxoplasma IgG was negative, but T. cruzi serology was positive, both by the Wiener assay and the hemogen assay. She did undergo ECG and a heart ultrasound. Both of them showed no abnormalities. By hospital day 5, she was continuing to get worse. So she underwent a lumbar puncture. And her CSF was stained and showed these little guys. So hopefully most of you recognize these as the trypomastogote forms of Trypanosoma cruzi. So that was a very slam dunk diagnosis once these trypomastogotes were seen in her CSF. So she was started on an anti-trypanosomal medicine, which hopefully all of you are familiar with, called benznidazole. After starting it, her mental status did start to improve. She was also started on antiretroviral therapy to treat her HIV, but that was not started until about 2 weeks after she had started benznidazole. She had another MRI done after the first 2 weeks of benznidazole, and it finally showed that the lesions were decreasing in size. She was discharged, and the last I spoke with her, about 6 months after discharge, she was doing really well. Her CD4 count had improved a lot, up to 359 at that point, and her viral load was almost undetectable. She still had some right-sided weakness, but mental status-wise was back to normal. And so one of the important points I just want to make sure you guys are thinking about here is that initial brain biopsy, which is a very invasive procedure that she got at the other hospital. These organisms, which were interpreted as tachyzoites, the active form of toxoplasma, these are actually T. cruzi, a mastigoteness. And so an astute pathologist would be able to tell. But another way to confirm is to do some sort of molecular testing of the tissue or the CSF if you don't visualize trypomastogotes in the actual CSF itself, like we did. Any questions about the case before I move on? Oh, and this case is published. Sorry, I just wanted to make sure to point that out. So if you guys want to read all the details, this is the citation here. It was published in the American Journal of Tropical Medicine in 2014. All right, so hopefully to test you guys' baseline knowledge on HIV before we move further into the presentation, I have another poll everywhere question, which is what immune cells are primarily targeted by the HIV? I'm glad I have at least one person doing poll everywhere. Let's see if we can't get some more audience responses. All right, great. Well, I see that choice A is popular, CD4 cells. And that is the answer I was going for. That's why, I added the word primarily. Some of your other immune cells, particularly macrophages, dendritic cells, are also targeted by HIV, but far and away, the immunologic problems are related to your CD4 cells being destroyed. So I want to use that knowledge as a way to introduce you guys to the challenges when a person is co-infected with both Trypanosoma cruzi and HIV. So first of all, just so I don't forget to remind you guys, if you don't know this already, um, a lot of times I'm asked, is Chagas disease more common in people with HIV? It is not. So the usually people are exposed to Trypanosoma cruzi in childhood, and so the prevalence of Chagas disease in a population of people with HIV is the same as that population without HIV. So think about that in your clinical practice. But Chagas disease itself is not any different from a chronic standpoint in people with HIV. So, having said that, it's very, very important to screen people with HIV when they enter care or to screen them at least once in their lifetime if they haven't been screened already. The logic there is very similar for, I think there's probably many audience members who take care of people with HIV. And I'm sure you guys are familiar with screening for another protozoa infection at entry to care, which is toxoplasma. And why do we do that? Well, the logic there is because while the person is healthy, we want to know what diseases they have been exposed to that do not go away, that could potentially reactivate if their immune system becomes very weak. So there are two protozoa that can do that if you've been exposed. One of them is Toxoplasma, and the other one is Trypanosoma cruzi. So if your patient meets criteria for screening for Chagas disease, and the most common criteria is that they've lived in continental Latin America for 6 months or more, they definitely should be screened, ideally at entry to care. So I'm showing you guys this graphic here on the left just to impress upon you the importance of CD4 T cells in the immune response to T. cruzi. So you can see they are critical. And so if you are a person with HIV who has not been on antiretroviral therapy and your CD4 count has dropped due to uncontrolled HIV, you are definitely at risk for reactivation of your chronic T. cruzi infection. So, my next question for you guys is what is the most common presentation of Chagas disease in people with HIV? I see everybody's getting the hang of poll everywhere questions. That's great. Right, and remember, question is, what is the most common presentation, right? So let's talk about that. So the answer is chronic Chagas disease. So for those of you who are taking care of people with HIV, if you think about the presentation of Chagas disease with your patient population, the vast majority of them are going to be asymptomatic if they have Chagas disease, and so therefore are in the chronic indeterminate phase. T-Cruzi reactivation disease is relatively rare. However, it is, very, very important to recognize when it happens. So before we talk about that, let's just talk about the natural history of Chagas disease. So I noticed on that last poll everywhere question that a couple of people were interested in the acute phase. So remember, the acute phase, and looks like I can't get a pointer to work here. Oh, yes, I can. So the acute phase happens, as I mentioned, usually in childhood, but it can happen just whenever in your lifetime you are initially exposed to the parasite that causes Chagas disease, which is Trypanosoma cruzi. Usually that's through being exposed to the contaminated fecal material of the triatamine or the kissing bug, although known very commonly by our patients as chinche. And then further south in the Americas, Benchuca, there are many common names, and I think all of you guys can recognize those. And I see that some audience members even have pictures of kissing bugs as their profile picture. So I know you guys are familiar. So when you're first exposed, your immune system has never seen T. cruzi before. So T. cruzi is able to replicate rapidly in your bloodstream. You can have very high parasitemia. And although most people we don't think have symptoms, if they are going to have symptoms at this acute stage, it is going to be flu-like symptoms. So usually, your Chagas disease infection, as I mentioned, occurs in childhood. And so, for most people with HIV, this is before they've acquired HIV. So, when most people are infected, their immune system is normal. And so, as I mentioned, they don't have symptoms. That goes hand in hand with being able to control your parasitemia without help. And so, your immune system controls your parasitemia, and then you either have no circulating T. cruzi or you have occasionally circulating T. cruzi. During this time, where is T. cruzi in your body? It likes muscle cells. And all of you guys know the most important muscle in your body is your heart. So unfortunately, T. cruzi, it likes to invade your cardiac muscle cells, set up shop there, and it can be difficult for your immune system to reach it there. So as far as parasitemia, just remember when you're in the chronic phase, when your immune system is normal, you usually do not have detectable parasitemia. If you do PCR for T. cruzi on the blood of a group of 100 people who have chronic Chagas disease, only about 40% of them will be positive at any given time. Now, let's talk about the meat of this whole presentation, though. So if you become immunocompromised, so let's say you have HIV and your CD4 count drops below 200 because you haven't been diagnosed yet, you haven't been started on antiretroviral therapy, well, then your immune system can no longer control T. cruzi, and you see parasite levels start to increase in your peripheral blood. The first sign of this, if you're doing testing, as is much more common in the post-transplant population, which Dr. Chen Hong will be talking about later, you can usually detect T. cruzi by PCR before any symptoms of reactivation disease develop. However, if you don't think about the possibility of this diagnosis and parasitemia continues, eventually the patient will develop symptoms. At that point, they can be positive by microscopy. For example, of the case presentation, our patient had positive microscopy of the CSF, but you can have microscopy of a positive for the peripheral blood. During all this time, of course, the higher the parasitemia, the more likely that the patient's going to have developed symptoms. So to define T. cruzi reactivation disease specifically for you guys, there are actually a couple of different definitions floating around out there. The definition does, to some degree, depend on what diagnostic tools are available to you. So traditionally, the diagnosis or the definition of T. cruzi reactivation disease is simply the presence of microscopically detectable T. cruzi, and that can be in any body fluid, blood, or tissue. Or an alternative and still accurate definition is the presence of clinical manifestations that are not typical for chronic Chagas disease. So we're not talking about people who are presenting with heart failure. We're not talking about people who are presenting with megaesophagus, megacolon. This is distinct from people presenting with the clinical manifestations of chronic Chagas disease. So any other symptoms plus T. cruzi identified in any kind of body tissue. So importantly, as I mentioned, for places that have T. cruzi PCR available, this is a very useful tool if you suspect T. cruzi reactivation disease in any kind of person who is immunocompromised. The difficulty here, of course, is that most places have difficulty accessing timely T. cruzi PCR or even any T. cruzi PCR. So in HIV, it's in the United States, usually T. cruzi PCR, we use it if we suspect T. cruzi reactivation disease. There's no monitoring protocol for people who are known to be co-infected, so a person with HIV and chronic Chagas disease. However, in the transplant community, there are well-developed protocols depending on the type of organ that's been transplanted, and Dr. Chin Hong will talk about that a little bit later. So just to finish up with T. cruzi reactivation disease, I wanted to impress upon everybody that this diagnosis is not made very often. And so, it's probably missed because most healthcare providers, even infectious disease providers who take care of a lot of people with advanced HIV, don't think about T. cruzi. So as of a couple of years ago, when we wrote this review, only these 6 cases had actually been published, and these are 6 cases of people with HIV and T. cruzi who were diagnosed with T. cruzi reactivation disease. So the case that I presented to you guys earlier is this one. You can see that we've had another case at our same hospital, so that's 2 of the cases. For those of you joining from Los Angeles, another couple of people, and then also North Carolina, and then another Californian case in Palo Alto. You guys see the countries of origin here. So our 2 cases in Houston were people from Honduras. Both Los Angeles cases were people from El Salvador. So don't forget that T. cruzi, it's relatively common in parts of Central America. This is not just a disease that's common in the Gran Chaco or the Southern Cone of South America. All right, so I think this is my final poll everywhere question for you guys. And so I just wanted to get your preliminary thoughts on what you think is the mortality rate of T. cruzi reactivation disease in people with HIV. What would be your best guess with the information I've given you so far? Okay, so drum roll, please. The mortality rate is greater than 75%. So this is very unfortunate, and the reason is because it is often diagnosed late, if it is diagnosed at all. And once it is diagnosed, clinicians have a lot of difficulty accessing antitrypanosomal medication. So benznidazole, as I mentioned earlier, is first line, but nifurtimox, of course, could be used too if you didn't have benznidazole. So to give you guys a recap here, the person with HIV who is co-infected with T. cruzi, their risk of developing T. cruzi reactivation disease is highest when their CD4 count drops below 200. So remember, CD4 cells, they're critical for defending you against protozoa like T. cruzi and toxoplasma, as well as various other viruses, endemic fungal organisms, etc. So T. cruzi reactivation disease is an opportunistic infection of people with HIV who also have T. cruzi. Another common question that I get is how common is T. cruzi reactivation disease in people with HIV? So to give you guys a number to work with, the answer is in people with HIV who are not on ART. Some of our South American studies, particularly in Argentina, have shown us that the cumulative incidence is between 15 and 20%. So this, of course, is going to depend on your population and their baseline prevalence of Chagas disease. The presentation, so just like our case, the presentation is usually meningoencephalitis or space-occupying ring-enhancing lesions. Another presentation that's less common but equally dangerous is actually myocarditis. We see that happen more often in the post-transplant immunocompromised population, but it can happen in people with advanced HIV as well. For diagnosis, you guys will remember from the case that I presented that that patient actually was seropositive by both the Wiener test and hemogen. However, there are plenty of studies that show us that when your CD4 cells are compromised, one of the possible consequences of that is that your humoral immunity is also compromised. So if you can't produce a good B cell response, you might not be able to produce a good serologic response to any serologic test, including those for Chagas disease. So if you have a high suspicion, even if serology is negative, definitely do blood and CSF smears, and also, if you can, do T. cruzi PCR of the CSF. For management, the most important thing I can teach you guys about management of T. cruzi reactivation disease is actually not about benznidazole or any antitrypanosomal drug. It's about fixing the immune system. So to date, there has not been a case of iris to T. cruzi ever documented. So you guys will remember with our case that I presented earlier, she did not start ART until about 2 weeks after benznidazole. That was unnecessary. So it probably would have helped her to start ART early because you need to reconstitute your patient's immune system. That is critical so that their immune system can start helping them fight T. cruzi. But you should also immediately start either benznidazole or nifurtimox. The vast majority of the published work on T. cruzi reactivation disease has used benznidazole, so that's why it's considered first-line therapy. Benznidazole works really great to kill T. cruzi when it's actively circulating. So, talk with your health system. Benznidazole right now, you can get it. So the only way to get it for most health systems is through benznidazoletablets.com. So that's the website of Exceltis, the distributor. But you can get it on formulary at your health center if you can work that out between your health center and Exceltis. Right now, I believe only Boston University and MedStar actually have benznidazole on formulary. Us at Harris Health, for a variety of reasons, we're only able to have nifurtimox on formulary. But check this out because you want to be prepared if you actually have a patient who needs it. And then just one last thing about management. There are, although certainly there are no RCTs or that level of data, there's a lot of published success stories about using benznidazole as secondary prophylaxis for people whose CD4 counts is less than 200. So this is something that some clinicians, particularly in South America, will do after a patient has been fully treated with benznidazole to keep somebody on, relatively low dose Monday, Wednesday, Friday benznidazole until the patient CD4 counts greater than 200. So something to think about. A question that I get from time to time is if you have a patient who is co-infected, but whose CD4 count is less than 200, but has no sign of T. cruzi reactivation disease, in addition to treating them for chronic Chagas disease, should you then keep them on benznidazole until their CD4 count is greater than 200? There is no data to support whether or not you should do that. I think that's an important conversation to have with the patient because benznidazole has some pretty significant side effects. But that's something we can discuss more if you guys want to hear about what we do and recommend in our center. Oh, I guess I lied. I had one more question for you guys. So, what is your opinion? What's the best way to prevent T. cruzi reactivation disease? Guys, be brave. It's not a trick question. So before you treat, what do you need to do? Yeah, improve screening. Excellent. For the person who said vaccination, there is no vaccine for T. cruzi. Unfortunately, maybe one day there will be. But yes, you need to screen your patients because you need to know if they're co-infected. So yes, that is the best way to prevent. And here, it doesn't matter if a patient has HIV or not. Any person in the Americas, who has a risk factor for Chagas disease, you should screen them while they're healthy. And that goes for people with HIV too. So remember, screen your patients who have risk factors for Chagas disease. And then, as I mentioned, if you do have a patient who is already diagnosed with chronic Chagas disease, whether or not they've already been treated, one strategy that's been suggested by experts in Brazil is to use T. cruzi PCR to monitor them weekly while their CD4 count's less than 200. That is not a common practice in the United States yet because we don't have easy access to T. cruzi PCR, but that might be something that we do in the future. This is much more common in the transplant community, so you guys will hear about it from Dr. Chen Hong in a little bit. And then just to reemphasize the important points of management, remember if you actually have somebody who you suspect or who you have diagnosed with T. cruzi reactivation disease, it's very important to restore their immune system. For people with HIV, that means starting antiretroviral therapy, unless there's some other reason, some other infection that they might have that could cause IRIS. You definitely should start ART as soon as possible. And then, of course, start benznidazole and treat for at least 60 days. Some people treat for 90 days. And then one last thing I'll leave you guys with. This is related to my earlier comment about how any serologic test, including serology for Chagas disease, might be less sensitive in people who have damaged immune systems. And so I just wanted to give you guys a little bit of US data on this. So in our health system, we screened 294 people with HIV presenting to outpatient clinic. And of those, 10 had positive serologic tests. And sorry, let me start over. So, of those, we tested all of them with three distinct serologic tests: Hemogen, Embio's, and Wiener, and by T-Cruzy PCR. And so we had 10 people who had positive serologic tests, and one person who had no positive serologic tests but only positive T-Cruise PCR. So this, of course, very small numbers. I just wanted to give you guys the data from our health center, but there are certainly larger studies out of South America that show this as well, out of Bolivia, Argentina, where people with advanced HIV are not positive by serology. They're only positive by PCR. So again, food for thought. It might be a good idea if you see a lot of people with HIV who have risk factors for Chagas disease, not only to start screening them, but also to figure out how you would send for T-Cruzy PCR if you needed to. All right, that's all I have for you guys today. Some take-home points. Again, I'm going to say as many times as I can, make sure you screen all of your patients for Chagas disease if they have a risk factor. And those use those, systemic opportunities for screening, such as entry to care for our people with HIV. And then, even though it's not very common, remember T-Cruzy reactivation disease has a very high mortality rate. It is a medical emergency. To manage it, you need to, number one, fix their immune system. So start ART in the case of people with HIV. Number two, start antitransdermal therapy, and first line would be benznidazole. All right, thank you guys very much. Happy to take any questions, or we can move on to the next talk if time is of the essence.
Thank you, Dr. Clark. That was great. Hi, everybody. I'm Paula Stigler-Granados from San Diego State University, and I'm just gonna jump in. And Dr. Clark, I think we're gonna take questions in the chat while Dr. Chin Hong gives his presentation. And just a really quick sort of housekeeping announcement. I think somehow Zoom has got a strange glitch and I've cloned myself multiple times on this call. So if you logged in via a link in an email that came out to you, you may have be seeing your name as Paula Granados. I just want to let you know I'm the real Paula. And if you can change your name, that'd be great. I know also, Dr. Chin Hong, you also state that it looks like your name is also wrong. We've got you though. I think we're going to make you a co-host right now. There we go. You can click on the three little dots in the corner, but you may not know which one of you are. So you might have to turn on your video, figure out which block is you, change your name, and then come back. And if you don't do that, that's okay too. Just put your name in the chat. And then really quickly, I know we've already introduced you, Dr. Chin Hong, earlier. I know you also have a work emergency and aren't going to be able to stay for questions. So I would just encourage everyone, if you have questions for Dr. Chin Hong during the presentation, go ahead and put them in the chat and we'll be sure to send them to you later. And maybe we can have a dialogue via email with some questions we can send to you. And thank you so much for being here. I know you've got a lot going on right now.
Yeah, sorry, something unexpected happened at work today. And thanks, Paula. And thanks, Ava, for presenting such a great and comprehensive review of HIV. So now I'm going to turn our attention to transplant patients and give you some of what we've learned so far. There are many of you who are experts on this call, so hopefully the collective wisdom of everyone will get us through where there's also not a lot of knowledge in some areas. So I'm going to start off with a case, which is a real case that I had, a 62-year-old Honduran-born woman who received an orthotopic heart transplant for progressive dilated cardiomyopathy, intractable to medical therapy. So 12 years prior to admission, she presented to her primary care physician in the US with symptoms of chest pain, weight gain, and fatigue. She was diagnosed with second-degree heart block, AV block, sorry. And astutely, he sent a Chagas serology test, which was positive at 1 to 512. And this was sent, at a commercial lab and then confirmed at the US CDC. And By 2 years prior to admission, she developed increased shortness of breath that eventually became refractory to medical care. And this was echo that looked like hers with a dilated left ventricle. So it's just very baggy and not able to pump the blood effectively. So because of this, over time, she underwent an orthotopic heart transplant. So the first question is how to best follow patients with Chagas. So she has chronic Chagas disease in the post-transplant setting. Do you monitor with PCR and microscopy? And there's like a regimen for weekly for the first 2 months, every 2 weeks during the third month, and then monthly until at least 6 months post-transplant. B is you don't monitor, but you follow closely clinically and test for fevers or signs of rejection. And C, prophylaxis with benznidazole post-transplant for 3 months. So if you just put it in the chat and Paula can just kind of give me what your general sense is, that'll be great. I realize this is kind of a specialized area, so please don't feel any pressure to get the right answer per se.
We have a couple of people answering already. We've got 2 votes for A and 1 for C. Anybody else want to 3 votes for A? Maybe have a shy audience.
Yeah, hopefully you won't be shy with some of the other questions, but the answer, I mean, the current practice is A. Of course, I hesitate to say what the answer is because again, who knows what if we had more data, what, it will show. But essentially what we do now is monitor, and that's based on a few things, historically and kind of current practice. C is probably not the most optimal management strategy right now, just because of side effects of the drug. The fact that there's a lot of polypharmacy in transplant patients, et cetera. Although we do prophylax transplant patients with lots of other things, so I don't understand why people might think that might be a useful strategy. For example, for CMV or for PCP pneumonia and things like that. So I think what we're trying to prevent by doing monitoring is reactivation of Chagas disease, just like in HIV, like what was talked about earlier. And in transplant patients, just like with HIV patients with low CD4 counts, it's due to failure of immune control with marked intracellular T-Cruzi replication. So how do patients present? Patient presents usually in the reactivation post-transplant setting with fever, myocarditis especially, evidence of rejection. So it may be, just heart failure or something even more subtle. Skin nodules, paniculitis, which is really inflammation of the fat. And you can see this picture, which shows kind of what paniculitis might look like, where a lot of action is going on in the fat cells under the epidermis. And it just looks red and it's tender. Or patients may be asymptomatic. And that's why we're doing all of this monitoring. We're trying to pick up people before they become symptomatic. So the reactivation risk is not well defined. The range in studies is generally 20 to 60%. I think one of the longest following studies is about 7 years in various series, and it may be related to different levels of immunosuppression. People always ask me, how is immunosuppression related? And really, immunosuppression is on a continuous scale. So you can have like very immune suppressed 10 out of 10 or not so immunosuppressed, depending on what regimen people are on, like 5 out of 10 or 4 out of 10. So there's a big range in what that means. So the more immunosuppressed you are, the higher the chance we think of reactivation. And reactivation may also happen in other organs, transplants as well, heart transplants, but also kidney transplants, stem cell transplants that we've talked about in previous conferences. So how do you diagnose Chagas reactivation post-transplant? You can certainly look at it clinically, like I gave you some of the clinical clues. We don't typically use serology. It's not as sensitive in the post-transplant setting. Plus, it doesn't give you an idea of activity of disease necessarily. Microscopy, certainly if you have very high levels of disease, you can do a peripheral blood smear or Buffy coat, uh, which is a definitive diagnosis and gold standard, but may not be as sensitive again in non-acute settings. And PCR has increased sensitivity since T. krusei has repetitive nuclear and kinoplast DNA sequences that can be amplified by PCR. So this is just an example of Buffy code from Karen Burns, Opus of a review several years ago. So what we do instead of waiting for people to have clinical evidence of reactivation in somebody who had Chagas before and then had a transplant is monitor them by PCR. And one of the earliest studies, which I think influenced a lot of the practice, was in Argentina. Not a very big study, but they had 10 consecutive patients with chronic T. krusei infection status post heart transplant. And they performed blood and tissue PCR and microscopy on all patients. 50% of the patients reactivated, and the PCR was positive in all the cases 59 days before the microscopy diagnosis, which makes a lot of sense that you're kind of picking up things preemptively before it gets into full-blown clinical disease. So the protocol for monitoring patients post-transplant is doing a T. krusei PCR and microscopy of the blood specimens weekly for the first 2 months, every 2 weeks during the third month, then monthly until at least 6 months post-transplant. And of course, if the patients had rejection, if they have a reason to have an increase in immunosuppression, if they have fevers, etc., we may modify the monitoring schedule or extend it beyond this particular time period. You've heard a lot about the treatment options in the last talk, so I'm not going to repeat much of it, except that, like in HIV patients, we prioritize benznidazole over nifurtimox, mainly because of terrible peripheral neuropathy that I've seen in patients on nifurtimox before. And both are FDA approved now. Duration of therapy is very much similar, about 60 days if you get a PCR that's positive. When you look at outcomes of people who've received heart transplants because of Chagas, which is in this top line here, you can see the outcomes are actually better than in people who've had heart transplants for other traditional settings like ischemic heart disease or other factors. And so basically, we use this to say that having Chagas is actually not a contraindication for transplant. In fact, they tend to be a little bit younger patients, and that might influence why their outcomes are a little bit better compared to the general heart transplant populations. And again, this is in the setting of monitoring and preemptive treatment if the PCR turns positive. So what happened to this patient? So again, to review, this is a 62-year-old woman born in Honduras who received a heart transplant for dilated cardiomyopathy. She was diagnosed with chronic Chagas before the transplant, and then she was monitored with PCR starting at 2 weeks post-transplant. I'm starting right after transplant, sorry, and at 2 weeks she became positive. Benznidazole was started. A last positive T. krusei PCR it went on positive until week 28. They gave a little bit extra until week 68, given some other circumstances like immunosuppression. And then her follow-up T. krusei PCR from her blood and heart tissue and Buffy coats were negative, actually now more than 5 years post-transplant. So I know the Met Gala recently happened, and it was a different theme, but my favorite Met Gala was 2 years ago when people seemed to have dressed as infectious diseases, like Lil Nas X, who dressed as crested scabies, and Rihanna, who dressed as an abscess. I don't know why I didn't get as much attention. So let's do another case right now. So this is a 37-year-old woman, status post a cadaveric kidney and pancreas transplant 6 weeks prior to admission, who presented with fever. And essentially what happened is got a blood smear and had T. cruzi, trypomastogotes all over the place. So in this case, the US CDC was contacted. The patient got nifurtimox. This was many years ago. The donor was investigated. It was an immigrant female from Central America. There were two other organ recipients from the same donor, a kidney and a liver, both also found to be infected with T. cruzii on hemoculture. And the outcome was a recurrent reactivation several weeks after completing therapy, and unfortunately died of Chagas myocarditis. So this was one of the original cases in the donor-derived infection from Chagas, where donor has Chagas, has no symptoms, donated organs, and then the recipients, got acute Chagas disease, and several of the individuals didn't have really great outcomes and died. So what do we know about donor-derived infection, where a donor of organs has Chagas, has no symptoms, and then what is the chance of passing it on to recipients? So first of all, it's not 100% chance of transmitting Chagas from an asymptomatic donor to a recipient. It depends on the organ. So in general, when you look at the literature, if you receive a heart from a donor who has Chagas, it's a 67% chance of transmission. A liver is 29%. A kidney is around 12 to 19%. And a stem cell, just to put it in perspective, is about 23%. So essentially, this is probably a marker also of immune suppression. You tend to suppress heart and liver and to some extent lungs much more than kidneys. Kidneys probably in general have the lowest level of immune suppression. So that might also impact the chances of transmission. And of course, heart, because of the tropism of the organism to the heart, that's probably the highest risk for multiple reasons. One, the highest chance of probability of transmission, but also the highest chance of a bad outcome like myocarditis that could result in a poor outcome. So because of that, I think what you'll see that I'll present soon is that generally with hearts from donors with Chagas disease, we tend not to take them, but we are okay with livers, kidneys, other organs, as long as we do monitoring post-transplant. How do transplant patients present in the donor-derived infection setting? Very similar to reactivation with fever, malaise, myocarditis. You can have CNS mass lesions, although probably not as common as HIV, and heart failure, particularly if you received a heart unknowingly. So what we do is monitor patients post-transplant from a donor with positive Chagas serology. And it's very similar to what we do in the reactivation to prevent reactivation in the person who had Chagas and is getting a heart, for example. Very similar protocol, PCR and microscopy, weekly for the first 2 months, every 2 weeks during the third month, and then monthly until at least 6 months post-transplant. And again, if the patient has had rejection, if they had some clinical suspicion of disease, or their immunosuppression is modified, we may change or extend that treatment, that period of monitoring. So on the right here is one of my patients who had a donor who had positive Chagas serology, and then we followed the patient post-transplant. You can see that in this particular patient, at week 4 post-transplant, the patient had a positive PCR. We started benznidazole, and then they started to have negative PCRs, and we stopped the benznidazole at week 12 post-transplant. So again, benznidazole is first-line treatment in this population. So the reason why this is, I think, such an important area in transplant patients is because so many of our donors come from areas that are endemic to Chagas disease. And even though this is an old graphic, I really love it because it really shows the patterns of migration from Central and South America to all over the world. And as these patients continue to migrate and become donors, it really behooves all people all over the world to really understand some of these issues that we're facing. Because again, I think a lot of times people probably have Chagas and recipients do, and they don't. People never diagnose it. So I think it may be also an invisible problem. So that leads to screening. A few of us several years ago got together to develop some early guidance for the transplant community. And right now, at that moment, we thought there was not enough evidence to suggest a universal screening strategy, but rather based on where the potential donor comes from. So asking a question, was a potential donor born in Latin America, South America, Central America, or Mexico, would be a good start, and recommending serologic testing for donors who answer yes on that question, or who was judged to come from that risk area. We recommended that transplant centers consider transplanting kidneys and livers from potential donors infected with T. cruzi, but advise against transplanting hearts from T. cruzi infected donors. Okay, again, coordination is key. We have to get a lot of people involved, the organ procurement organizations who manage the organ distribution, UNOS, the regulatory body, and local transplant infectious disease specialists, state health authorities, and the CDC. And of course, reporting the transmission event when it's known. So we did a sort of screening before these guidelines came out to figure out how many people are actually doing screening. We're able to get like 100% response from all these organ procurement organizations. And at the time, there were about 20% of OPO said they were screened, a little less than 20%. But, based on our information, about 45% of that said they would do screening eventually. So just remember that number, 20%. So what do you think the proportion of OPOs that are now screening for Chagas about 10 years later after after we did all that education and, publicized this more? So you can put it in the chat. This is one where, you really can guess anything because you would know the answer. So that's why I'm hoping for more participation. I can't see the chat, so if Paula, you can help me, that'd be
It
great.
looks like we have mostly, well, we have a kind of a tie, but we count between B and C. We have one, two, three, four, five.
Great.
Five for C and the rest for B, so mostly B.
Yeah, so some pessimistic viewpoints and some more optimistic. Unfortunately, I'm kind of an optimistic person in general, but even I was kind of shocked even 10 years later after the 20% of people were screening OPOs, and now in 2021, when this is published, 2020, about 37% of people were screening. And you can see that in the other things where we're trying to get, it's kind of a no-brainer for screening, like strongyloides, where you can only have benefit, and ivermectin is so easy to get and so easy to take that only 24% of OPOs are screening for that, and 39% for West Nile. So a long way to still go, but there's some inroads being made where it has been passed by OPTN that everyone should screen based on a risk perspective for Chagas, and it hasn't been operationalized as yet. So the risk of, just take home points, the risk of reactivation following heart transplant in patients with a history of Chagas is high. So that's if somebody who had Chagas, they get a heart transplant, that needs to be followed. So diagnosis of reactivation includes clinical features, serologic diagnostics. You can check a peripheral blood smear, tissue, but most commonly we do PCR. And donor-derived infections from donors with Chagas infection can be devastating. like in that patient with myocarditis that I presented. More OPOs need to do screening, and there's some movement towards that. But again, the devil is always in the details. I know talking to Sue Montgomery recently from the CDC, it has to do with getting the confirmatory tests, and some of these details need to be worked out. But it's kind of a no-brainer that I think we really need to have more universal Chagas screening for those at risk in the transplant population. So in terms of organ utilization, we consider transplanting kidneys and livers from donors with positive Chagas, but advise against hearts. In fact, the last donor-derived infection, even after all this, did result in myocarditis from Sue's data. And in terms of monitoring, very similar in both cases of reactivation and in following patients post-transplant from a donor who's positive, PCR and microscopy weekly for months 1 and 2, and then every 2 weeks for month 3, and then monthly for at least 6 months. And treatment is benzandazole, which is more tolerable than nifurtimox and is first line. So just ending with a picture of Rio again, just to remind me of where the Chagas Institute is. And thanks for your attention. And unfortunately, I have to go back to the stuff at work now, but I'll be happy to answer questions asynchronously. I really appreciate the opportunity to present.
Thank you so very much, Dr. Chin Hong. We appreciate you. We'll send you messages if we have them.
Thank you.
Thank you. All right. Well, thank you all so much. This was the end of our presentations. We do still have time for Q&A. I believe Dr. Clark is still with us. Is that correct? Yes.
I am here.
Hi, thank you for staying. We appreciate Dr. Chin Hong. I know he had a pretty critical emergency happening. So I'd like to kind of just open it up. If people have questions, can unmute yourself or put it in the chat, whatever is your preference. That was a lot of information that was shared today. Maybe I have a question I can start us off with, Dr. Clark. I know, and you may have even said this in your presentation, but after I was watching Dr. Chin Hong's presentation, now I have a lot of extra questions in my head, processing all of that great information. But like he was saying, with percent of population that's being screened for, the organs are being screened, universal screenings for Chagas disease. And I know it's very low also for HIV patients. What do you think would be a good strategy for providers that are treating HIV patients? I think you've already said it, but maybe just to sort of expand on that a little bit more of like, what sort of advice would you give providers, especially, and I don't know if this is true or not being a medical doctor, but is HIV now more treatable at the PC level, or is it still referred out to ID docs? And if it's being treated by primary care or somewhere within that, realm, what type of information would you share with those providers on how to and who to screen and what to do next?
Yeah, so thanks for that question, those questions, Paula. To answer the first one about what strategies we use to try to improve screening among our patients with HIV. So most centers in the United States still have dedicated HIV clinics that are either standalone clinics or are part of another clinic that does primary care. So in our system, we have both, and we've done a lot of different things to improve screening for both the general population and specifically for our patients with HIV. So to give you our example, we have 2 nurse practitioners who see all of our patients with HIV for their entry to care visit. So that's a very manageable number of nurse practitioners. Even though we have a huge HIV practice, we have one of the largest clinics in the country. We see about 5,000 people with HIV a year. But I trained our nurse practitioners. So when they do the entry to care labs, which are very standardized for people with HIV, they simply ask the patient, have you resided for 6 months or more in continental Latin America? And if the answer is yes, they add a T-Cruzi serology to their screening panel. Now, of course, there's ways we could improve upon that. There's, especially since we're in Texas, as you know, Paula, there are other risk factors for Chagas. For example, one of the nationally recognized risk factors is if you can recognize a kissing bug, which many people who've never left Texas sure can. 50% of the kissing bugs in Texas that have been turned into the health department are positive for T. cruzi. So we haven't arrived at that level yet. But we simply have trained our nurse practitioners to ask that one question about whether or not you've resided for 6 months or more in continental Latin America. If you have, the answer is yes. And so between that and we over since 2022, we have done a lot of provider education lectures. And so, you know, unfortunately, Chagas disease is not a topic that healthcare professionals, whether those are doctors, pharmacists, nurses, PAs of any type, are trained about regularly, even though it is an infection that we have and see relatively commonly in the US. And so we have started having regular provider sessions actually on screening of foreign-born people and travelers, because there are a lot of asymptomatic infections that you can prevent sequela down the road if you go ahead and screen and treat now. Chagas is one of those. So that's just one example. To answer your second question about whether or not primary care doctors are starting to do HIV treatment, they certainly are. So in some health systems, primary care has taken on initiation of antiretroviral therapy. However, I think still, certainly in our center, but nationally, I think it still mostly falls within the realm of infectious disease physicians. And that's mostly because while starting a one pill once a day regimen is relatively easy, depending on the funding, if you actually have drug resistance or drug interactions, complications, et cetera, that can be much more challenging and often requires the input of an infectious disease specialist. But certainly, lots of different types of primary care in the United States are taking on starting antiretroviral therapy.
Thank you. We had a comment from Dr. Tobin saying a lot of PC clinicians and FQHCs are treating HIV. And then also we hope that a lot of this outreach to those FQHCs about Chagas disease screening in their populations is also, being heard. I was gonna also add, being in the southern US, you and I both have talked about this many times about that local risk, which you mentioned as well. What do you think, because of the severity, I guess, of the disease of Chagas disease within an HIV patient, what do you think it would take for like southern states to sort of more frequently add that Chagas disease screening to their population, maybe per se, not just with that, have you lived 6 months or more, or do you recognize, but maybe if you live in a rural area, do you think, because we've looked at, triatamines in rural areas being a little bit more common, I'm wondering if that would be something that's sort of on the radar.
Paula, that's a great question. Of course, you're not going to surprise to hear me say that the answer is funding. So, in Texas, and so many HIV clinics in the United States are funded by the National Ryan White program, and that will fund HIV care. It does not fund medicines, but it does fund provider visits, labs, et cetera. Many different types of clinics, including many FQHCs that are funded by Ryan White. Unfortunately, Ryan White funding is not going to be expanded anymore, but we're glad it still exists. It does cover Chagas disease screening as part of entry to care labs. most insurances, and I don't want to be pinned to the board here because I, of course, don't know about all insurances, but most of them do cover screening. So if a clinician or their clinic, has access to a large diagnostics lab like Quest or LabCorp, then they will be able to send routine serology. In Texas, we're very lucky because we have, I believe, still the only state health department that will do two distinct serologic tests, hemogen and wiener, for free. So in Texas, you can always be screened for free. Other states, I've certainly been made aware of many challenges to covering the cost of screening tests. So there, I don't have a great answer. If there was funding available, that of course would help solve a lot of our problems. Chagas is definitely not a priority in HIV. As you can imagine, the priorities are generally related to retention and care. So getting people to come to visits, keeping them on their medicine. In the southeastern United States, we have not overcome those basic challenges yet. And so, unfortunately, anything on top of that generally is a secondary priority.
Thank you. And then we have a couple of questions in the chat. I think one of them you may have already answered, but I'll read it anyway. When you test individuals for HIV and they are positive, do you usually test them for Chagas if they live outside of Texas?
So, so not many clinics or providers in the United States screen anybody for Chagas, whether you have HIV or not. So the screening for anyone with a risk factor needs to be improved across the board. In our national HIV guidelines, yes, if you read in the section about Chagas disease, screening is addressed. It's a smart thing to do. But having something in the guidelines and then it moving into actual practice is completely different. So certainly in our center, it's routine now, but there are very few centers in the U.S. that are dedicated to people with HIV where screening for Chagas disease is routine. I will also add that it makes sense in our population because we have a huge proportion of people who are at risk for Chagas disease. If you're practicing somewhere where, like Vermont, or I'm just going to pick on Vermont, let's just say you're in a small town that doesn't have a lot of people who have come from Chagas endemic countries or who have traveled in Chagas endemic countries. T. cruzi is not endemic in kissing bugs in Vermont. There are no kissing bugs in Vermont. So that would definitely probably not be something that Vermont clinicians are necessarily worried about unless they work like in refugee health or something. But in our situation in Houston, Texas, it definitely makes sense, even from a cost analysis perspective.
Thank you. Got a few more questions. Do we know why some people with HIV who have low CD4 counts never develop reactivation despite chronic infections? Is this due to strain differences and load or what?
Yeah, this great question. So we do not know the answer to that. And I will extrapolate your question to all other opportunistic infections. So, for example, you guys are probably familiar with pneumocystis pneumonia. So many of us, if you tested all of us right now, many of us have pneumocystis in our lungs. If all of us became immunocompromised over the next few weeks, only a small proportion, at least initially, would reactivate, right? If we weren't started on ART or our immune system was restored. So the answer to that, it's unclear, but over time, the number increases, right? So it's related to a lot of different factors for sure about your bone marrow. So while you still have at least a few good healthy CD4 cells, you can protect yourself, but we don't know, there are no studies that indicate how long it takes, et cetera. So that is definitely a research question that, some groups are actually looking at that, but you can only do it in places that actually have a large proportion of people who are co-infected with T. cruzi and HIV. So you'll see the biggest HIV T. cruzi co-infection studies are in Argentina, Bolivia. Those are the main places. But in the US, it's hard because we don't have a huge number of co-infected people.
And also just to add, we're also not screening very much, so we don't really know how many
Aha.
co-infected people we have.
Yeah, we're not screening and we definitely aren't diagnosing
Mhm.
people. But honestly, for all of you who see inpatients with advanced HIV, if you think of toxoplasma, you should immediately think of Trypanosoma cruzi as well.
Thank you. Another question, if you treat HIV patients that are positive for Chagas, do they recover from Chagas? Or is viral load make the symptoms of Chagas disease worse?
Um, so if you, okay, so let me break that question down a little bit. So if you have chronic Chagas disease and you are an adult, it is almost impossible to cure you, regardless of whether you have HIV. So our current medications that are effective, which are benznidazole and nifurtimox against trypanosomes, they work great for active circulating parasitemia, as they do not work well in the like a mastigos, which are the form of T. cruzi that are embedded in the tissue. So this is why it's very important to screen people for Chagas disease as early in life as possible, because you're more likely to cure them with anti-trypanosomal therapy. So that's the first part of my answer to your question. Now, therefore, if let's say you have a person with HIV, you're a great clinician, you screen them at entry to care, they're positive, you do confirmatory testing for Chagas disease, it's positive, you have diagnosed them with chronic Chagas disease, right? Because they're asymptomatic. You then treat them with 60 days of benznidazole if they're eligible, which I can talk more about if you guys would like me to. At that point, they are still at risk for T. cruzi reactivation disease because we have no test of cure for Chagas disease yet. So if they are then become immunocompromised, even though they've been treated, it is possible that they could still reactivate. We like to think that their risk of reactivation is much lower. This is akin to treatment for latent tuberculosis, right? So you diagnose someone with, someone's skin test or their blood test is positive for tuberculosis. You treat them for latent tuberculosis for, 4 to 6 months, whichever regimen you're using. You then congratulate them on finishing and tell them that we're all excited about your risk for developing active tuberculosis in the future being low, but it's not zero. So same story for T. cruzi, unfortunately.
Great, thank you. Any other questions? These are really great, Dr. Clark. We really appreciate you sharing all your knowledge. This is such a super fascinating topic. This and the organ transplants, it's not something I think in our Chagas world, we talk as much about as I wish we did. It seems like it's very specialized, but it's not as much as we think it is. And I do think it's, like you said, interesting to see that our colleagues in Latin America have so much more research done on this because, they're doing a lot more screening and um, yeah. So I mean, we're always still on that debate of, how much local transmission is really happening in the United States, and the answer is we don't really know. It's again funding and resources, all of those things are a factor. So um, I'm going to ask if my colleagues can show our last slide. We do have a QR code if you want to screen grab that with your phone for a quick evaluation. And we've also got a link in the chat. And I'm just going to see if there's any more questions that anyone might have. Not opposed to ending 5 minutes early, but I also don't want to cut anyone off from a chance of answering a question, asking a question. Okay, well, with that, I want to say thank you to both of our speakers, to UT Health, Echo, our team, for all of the funders for this, especially our CDC cooperative agreement, Dr. Sue Montgomery for her support in these Echo sessions, and our partnership with CDN. This was the last in our four-part series. However, we remain available for questions, thoughts, anything, resources that we can provide for you. Our contact information you can find pretty easily. We will post the recording from this session on both the UT Health Echoes website as well as CDN. And I believe that CDN also you can share this link with your colleagues to get CME by watching the recording of this on their website as well. There we go. We have a link from Dr. Tobin in the chat. Thank you so very much. And with that, I just want to say thank you all very much. I hope you have a wonderful weekend. And for those of you doing Mother's Day this weekend, I hope you enjoy that, or just anybody who's doing anything relaxing this weekend, hopefully you get some time off. But thank you for being here. We appreciate you. And thank you again, Dr. Clark.